pericardial effusion results from different disease processes such as malignancies, infections, immunologic disorders, and trauma. Most importantly, iatrogenic injuries such as those associated with catheter-based interventions. With increasing volume of pericardial effusion, there is eventually compression of the cardiac chambers with a subsequent decline of cardiac output and hemodynamic compromise, a condition that is defined as cardiac tamponade. Clinically, cardiac tamponade can present with anything between a mildly symptomatic patient with exertional dyspnea up to frank hemodynamic collapse. Typical clinical signs of cardiac tamponade include hypotension, tachycardia, muffled heart sounds, and distension of the neck veins. If hemodynamic arterial blood pressure monitoring is available, one can also note pulsus paradoxus, which is defined as an inspiratory decline of systolic blood pressure of 10 millimeters mercury or more. Indications for pericardiocentesis include cardiac tamponade or pleural effusions with imminent cardiac tamponade, and sometimes can also include conditions that require diagnostic puncture of the pericardium. There are no absolute contraindications for pericardiocentesis. However, there are conditions that require special considerations where pericardiocentesis can lead to acceleration of blood loss, such as aortic dissection or ventricular rupture. Before pericardiocentesis, coagulation status should be checked. Ideally, INR should be below 2. Platelet count should be above 50,000 and PTT below 50 seconds. So let's now take a look at the equipment. We have everything here on the table. First off, we need a local anesthetic, of course. We need a pericardiocentesis needle, which is a little longer than the needles we usually use. We need a J-tip wire, which is 0.035 inches. We have a scalpel. We have a dilator that we use over the wire, of course, and we have the pigtail catheter to insert into the pericardial space over the wire. We have a 50 cc syringe and a collection bag. Echo is the most important tool for the diagnosis of pericardial effusion, but also with regard to pericardiocentesis to find the optimal access site. Within the framework of our discussion now, we're just going to look at the most typical access site, which is the subxiphoid site. And I'm going to demonstrate you how to use echo in this condition. So we do this right before the procedure. The patient is positioned in a supine position with the upper body upright at an angle of about 30 to 45 degrees, so that the effusion collects within the inferior part of the pericardial space. We will, of course, look for a subxiphoid window in order to see the heart and the pericardium. And it is now important to note the trajectory of the echo probe, which is going to be the trajectory of the needle that we use for puncture. And it's also good to note the depth of the pericardial effusion, which of course can be measured with the echo, and which helps to find the pericardial space later. So we are now going to start with the local anesthesia, which we gonna apply in the subxiphoidal space according to the trajectory that we identified in the echo. Jetzt wird es ein bisschen pieksen. Nicht erschrecken. I will first just inject local anesthetic very superficially in order to minimize the pain for the patient. As noted on the echo, we have a depth of 6.3 centimeters until we will reach the pericardial effusion. So I commonly first use a smaller needle like this one and then switch with more anesthetic to a larger needle. At the same time, we administered the patient pyridramid for analgesia and also midazolam for sedation. So this can be sustained quite well. And I always infiltrate the tissue along the trajectory that we saw on the echo to have perfect analgesia here. Now I'm mounting the pericardiocentesis needle on a syringe with saline. Then I prepare the J-tip wire that we saw before. And now along the trajectory that we identified with the echo, under permanent suction, I try to reach the pericardial space. Now there's clear fluid coming out, and I insert the wire. Which should go in easily. Now with the needle in place and the wire inserted in the pericardial space, there are different things we can do to make sure that we are indeed in the pericardial space. Here in the cath lab, of course, we can use fluoroscopy in order to take a look at the path of the wire, which is what I will do now. So here we can see the wire, how it wraps around the heart and it moves freely in the pericardial space, which is, as I said, one thing you can do. You could also clamp an alligator clamp to the needle and record electrocardiogram where when you hit the myocardium you would see ST segment depression. You could also use echo, which of course would have to be sterile then, and you could inject agitated saline over the needle in order to ensure the correct position of the wire. So the next thing will be to remove the needle. Of course, we will keep the wire in place. And to make a little cut with the scalpel in order to come in easier with the dilator. The next step is now the dilator. Ist es in Ordnung für Sie? Alles gut? This can be a bit painful for the patient, so you have to do this carefully. And it usually should go in without resistance. All the way, and you have to loosen up the tissue a bit because the pigtail is quite a large catheter. Now I'm removing the dilator over the wire. And I'm going to put in the pigtail catheter, which is of course pre-flushed with saline. Pull the wire out so I can see it. And then with little wiggling movements, I put in the pigtail catheter all the way. Tut ein bisschen weh, ne? And then you can see that clear fluid is coming out here, which is of course always a sign that you're correct, but there are of course also hemorrhagic effusions where you can't use this as a sign. So now I'm removing the wire And I'm connecting my tube here via a 3-way stopcock, which we now connect to the collection bag. And I'm going to use the 50 cc syringe to collect the fluid. You can see very clear pericardial effusion. So the first part we are going to use for lab analysis. What we will do is we will send in the material for bacterial culture. We will look for cytology and also for clinical chemistry. I have the pigtail catheter still far in, so I still have the option to pull it out when it is in a space where the catheter sucks to the tissue and therefore does not allow to produce more fluid out of the pericardial space. I always apply very little pressure in order to, or not to injure something. Now it's difficult. So the final step is just to put a suture on the pigtail. We leave it usually for around at least 12 hours in the patient to see if there will be further effusion. And of course, according to that, we will then remove the catheter at least within 24 hours or sooner if possible. So, as you were able to see, pericardiocentesis can be performed safely and is an easy-to-do procedure. In our opinion, the most important step is the echocardiographic planning in order to have the diagnosis, in order to identify an access site and to identify the trajectory and the depth where you will hit the pericardial effusion. And as long as you keep this trajectory in mind and the depth, it's very easy to steer the needle to the pericardial effusion and to have a safe procedure.